out, we have Dr. Rich Denson from the NICU here at Mckay Dee. He's going to come talk to us today, so we're really grateful that she took the time to do that. I actually had the opportunity to shadow her, and she's really awesome. And her, one of her big priorities was making sure that all the candy jars were filled every morning, right? For all the nursing staff. But everyone loves her. She's an awesome physician, very thorough and really knowledgeable. And yeah, so ask questions, be involved. She's going to answer them. As far as activities coming up next week, we're going to go through application and process, like what the AMCAS application looks like, kind of things you need to know there, and maybe some things that would be wise for you to start doing now before you apply, so it's just easier when it gets to that time. So I think that'll be really beneficial for you, especially if you're going to be applying here soon. If not, we're going to be talking about activities and how you can get the most out of those as well, and how important those are too. And then the following week is a personal statement seminar thing from Dr. Fritzler. He's going to talk to us about how to write a good personal statement, which is really important for anyone. And the sooner you can get working on that and fine-tuning that, the better. And then I think it's our closing social after that, right? And we're done with the semester. So yeah, so that's what's going on now. Any questions for me or anyone else from AMSA? Okay, cool. We'll give the rest of the time to Dr. Rich Denson.
Said I was Dr. Fuller, but I am indeed not Dr. Fuller. Dr. Fuller is at the NICU covering the babies because I am here instead of at the NICU. So, I'm Carolyn Rich Denson. I'm a neonatologist at Mckay Dee Hospital. I recognize the green. Go Volunteers. I used to wear pink, so I think the green's a nice improvement. My route to medical school and where I am now is that I did my undergraduate at University of California at Santa Cruz and was living in Santa Cruz at the time. So when I applied to medical school, I applied most of the California schools along with the billions and billions of California students that apply to California schools, applied to University of Utah and a couple of other schools. We had no pre-med advisor. I just did everything on my own, and I just kind of tried to figure out this. Did not get in. So I moved back to Utah to get a second bachelor's degree, which was in, at that time, medical technology, which is now clinical laboratory science, which I encouraged my daughter to do, and she is now working in clinical laboratory science. Imagine getting a bachelor's degree and then getting a job in the field you got your bachelor's degree in. I mean, who does that? So I applied again, but I was still considered a California resident. Did not get in. Actually, the second time, and then I got the second bachelor's degree. Took a year off to get the second bachelor's degree because all my pre-med stuff pretty much got me most of what I needed. So then I applied the third time and only to the U because as my son, who was finishing his emergency medicine residency, proclaimed, he says, you got in because you were a woman, they needed more women. Probably true. Because I was actually not going to apply to medical school again, and I actually got a call when I was in the lab working as a med tech from a female medical student at the U who says, are you applying again? I said, I wasn't thinking of it. She goes, you should. Okay, I need to hit MCAT again. No, you don't. So somehow being of gender female, I probably did help because at the time, in my year at the University of Utah, there were 20 women out of 100, which is one of the lowest in the nation, and they needed to improve their stats. But I think, all in all, I'm actually a pretty good doctor, despite the fact that I may have slid in because I was, there were no requirements for shadowing hours and administrative hours and research and all the stuff I watched my daughter go through. You had your MCAT score, you had your grades, and you had 3 or 4 letters of recommendation, and that's what they looked at. So I finished the University of Utah medical school 10 years after I graduated from high school, so it took me 10 years to get my 2 bachelors and finish medical school. I had a daughter at the time that I graduated medical school. She was a year old when I started, so she was 5 when I graduated. I went to the University of Arizona for my pediatric residency. and figured I'd be a pediatrician. My father's a pediatrician. That's all I'd ever known growing up was my father being a pediatrician, but that's what I would be too. So I planned on pediatrics and was doing a pediatric residency. And during my second month, when I was in the newborn ICU, I decided this is where life is. This is what I wanted to do. I love the pace of the intensive care. I love taking care of babies. And it's kind of like veterinary medicine. You have a patient who cannot talk with you, and you have crazy parents. So, but it was a good field for me, and it's actually been a really, really good field because I since then became a single parent and remarried and had 3 more kids and became a single parent again. And being in the NICU, I can work my 12-hour shifts. I work, depending on, I mean, at one time I was 12 shifts a month. I'm now down to 9 shifts a month. And in 15 more shifts, I will retire and be all done, who's counting. So it's a great way to have a family and be home. I'm there for my shifts and I'm home. I am leaving tomorrow morning to go to Guyana on a humanitarian trip. I have been working with the LDS Church's humanitarian arm called LDS Charities and going out to countries where they have high infant mortality rates. We teach them life-saving skills called newborn resuscitation program or helping babies breathe. It's another program we teach. And I've been on 11 trips to 8 countries, and tomorrow will be my 12th trip to 9 countries. So I can use my skills that as a physician to better the world and see amazing destinations like Armenia, Bosnia, Montenegro, Rwanda, Uzbekistan, you gotta look that one up on the map, Tajikistan, Russia 3 times, Romania, and then the Guyana coming up. So, ask me questions if you have questions, but one thing I want to make sure that you guys know is that what you're going through is really very, very hard. Getting through college and all the classes that you have to take, but it is a prelude to what medical school is like. Medical school is hard. Medical school is a lot of time, it's a lot of effort. For those of you who have families, you will not see them very much. My oldest daughter was 3 during my 3rd year clerkship, which is when you're doing your rotations through surgery and peds and internal medicine, all those. When I was doing my surgery clerkship, I was on call every 3rd night. Oh, and this was before those hour things they limit you at, you know, how you can only work so many hours per week. She drew a picture for me on yellow legal paper. It was a flower that was black. And she wrote, "Dear Mom, I hope you love me." So it's hard. You will not see your children much. Quality of time, not quantity of time. We actually had several people get married during medical school, not married. It was hard. Like I said, I was one of 20 women. We had one woman drop out during 4 years, which was unusual because usually medical schools, when you interview and they'll talk with you, the weeding out process occurs during the application process. You know, back when my father was going to medical school, it was very cutthroat. And he tried to sabotage your partner's experiments so that they would get kicked out because not everybody was expected to graduate. Now, everybody's expected to graduate, and they will bend over backwards, getting you tutoring, getting you help. If you're struggling in chemistry or pharmacology, they will get help for you. Because if they send you an acceptance letter, they want you to get your MD. They want you to finish, so they will do everything they can to help you. So after medical school, I went to Tucson, Arizona for my pediatric residency. Tucson was great. People say, wasn't it too hot? And I said, what do you mean wasn't it too hot? You went to the hospital when it was 6:30 in the morning and you left when it was 10 o'clock at night. I mean, it's not too hot. You just you're in the hospital all the time. But here again, we had no limitation of hours. So if we were really lucky, we were on call every 4th night. Otherwise, it was every 3rd night. And being there for 36 hours was not unusual. So I have mixed feelings about the whole limitation of hours that residents can have, and that think about the surgeons that are coming out with the limitation of hours. They've done how many fewer appendectomies, how many fewer gallbladders, how many fewer surgeries than back in the old days, you know, always. So that was residency. Residency is also very hard. I went through a divorce during my internship of my residency year. didn't see my daughter a whole lot, but her dad was very involved with her at the time. So once I finished residency, I then applied to fellowships. I had realized I really want to do the NICU. And I applied to a number of schools. I remember when I was in San Diego interviewing, I was asking, well, how much vacation do you have to get here? They said, well, you don't. You just trade shifts with somebody else to get time off, which didn't sound like a fun deal to me. But I ended up going back to the University of Utah for my fellowship. I took the 4-year plan instead of the 3-year plan in that I got pregnant and had my son David, and so they gave me 6 months off. And I just had to pay them back 6 months. And then I had Leslie, and took 6 months off and had to pay them back 6 months. So I did 4 years of residency instead of just, actually I guess 3 years instead of 2. And after that, I stayed there for a year as a limited term instructor because I didn't have another job to go to. I then became a part-time neonatologist, which as a neonatologist you could do. And I worked part-time I was living in Tucson, Arizona, because that's where my husband's living. And I worked part-time in Flagstaff, Arizona, and in Yuma, Arizona. So I would drive 5 hours to the Flagstaff or to Yuma and cover from Thursday night through Monday morning, kind of cover the outlying settlements, as I like to call them, so that the doc out there could then have some time off. And that was great, because I could then get a babysitter with the kids, and I could practice my specialty. I was notified when I was down in Arizona that they wanted to know if I wanted to move to Utah for a NICU job. Larry Everett called me. I said, well, I only want to work part-time. They created a half-time job position for me. He knew me from, I'd done some moonlighting with Mckay Dee, so they created a half-time job position for me, and that worked into full-time. Who's now winding down towards retirement. So that's kind of how I got to where I am now. And what I am doing now is, anybody familiar with newborn intensive care? I mean, you've done some shadowing, have children or siblings who were patients in the newborn intensive care. You never want that. Nobody wants me to walk in the room and say, hi, I'm Dr. Rich Denson. I'm to talk to you about your baby. Nobody. I mean, I cannot tell you as many parents I've brought to tears. I'm just walking into the room and introducing myself. Because nobody wants a baby in the ICU. But they have to be there sometimes, and that's why we got there. My train of thought just derailed. It's gone. So what I do now for my job is I work in the newborn ICU. We take care of preemies. We take care of sick newborns who cannot go out to the regular nursery. And we keep them with us until they're ready to go home and get taken care of by their pediatricians or their family practice physicians. Right now, the nursery is very slow. I've only got 12 babies in there, so 5 or 6 nurses get called off every shift, which is a hardship for them, with all their PTO. It's been as high as 43 babies. So I have no way of increasing my patient load or decreasing my patient load. I can't earn more money by seeing more patients because I just get what comes to me. So the smallest baby that I've taken care of is 12 ounces. So think of a pound of hamburger. Cut off a piece of it to get it down to 12 ounces and kind of mold that into a little baby thing. Just a little tiny. That guy jokingly tell people I'm a woman of little patience. That baby was what we call small for gestational age. The limits of viability are somewhere around 24 weeks gestation. We have saved 23 weekers. We have saved some twins who were 22 weeks who were in there forever and ever and have some developmental delays, but the parents are thrilled it's their last chance to have children. So that baby was 27 weeks gestation, but was small for gestational age. And those are much, much better because the organs have matured, the lungs, the brain, the liver, everything else have matured as if they were 27 weeks, but the baby was just very small because mom had a liver transplant and she was on anti-rejection drugs and the baby didn't grow very well. So that baby survived in my home. For the most part, it's a happy job. Babies do well, and they get to go home with their families. Sometimes the families are crazy, sometimes they're actually pretty safe. We take care of big babies who are just like an infant of a diabetic mother whose blood sugar drops down very low and has to be supported with IV sugar until you're looking complex. Why would an infant of a diabetic mother have low blood sugar? Is that what you're asking?
Yeah.
Great story. Let me tell you a story. Mom's mom's a diabetic. She has high blood sugars. She's not keeping it well under control. She likes to eat Twinkies and Coke. So she's running high blood sugars. High blood sugars cross the placenta into the baby. So the baby is seeing high blood sugars. Mom then takes her insulin, brings her sugar down. Insulin's a big old molecule. It can't cross the placenta. But the baby is smart, makes his own insulin. So if mom's sugars are always high, then baby has this really high level of insulin to get his blood sugars down. Baby's born, you cut the cord. There's no more sugar coming in from mom. Baby has all this insulin. Sugars plummet. So until that pancreas kind of quiets down, settles down, we have to support the baby with IV sugar feeds to keep the baby the normal sugar. Just 2 hours ago, I was dealing with a baby in the transition nursery whose mother was a diabetic, and the baby's first sugar was, we measured on something called a glucometer, which is a little drop, and you read it, and I said, whoa, okay. The baby's telling me, feed me, I need to eat, give me some sugar, give me sugar. Movie reference. Anybody know that movie reference? I know you know it, Leslie. Got it. Oh, what did you say? Yes, Men in Black. Give me sugar. So we fed the baby that came up to 40, which if you or I had a blood sugar of 40, we would be passed out on the ground. But a newborn baby with a sugar of 40 is just fine. So we deal with those kind of things. We will transport babies to primary children's hospital with something that we cannot take care of. Congenital heart defects, surgical emergencies. And oftentimes those don't come to us because with all the prenatal diagnosis that moms get, they will oftentimes identify those with prenatal ultrasounds, and mom will know to deliver down to you where they have the surgeons right across the bridge to primary children's. But sometimes one will sneak in on us and we'll get a surgical emergency or a cardiac defect that's not picked up, and then we'll stabilize those babies and transport them off to primary children's. A lot of times our babies are what we call feeder growers. You know, once you've gotten through the initial lung disease of prematurity, which babies have, they then just need to learn to feed and get to a gestational age where they can go home. Even if a baby has no lung disease, there's no infection from maternal chorioamnionitis, a baby at 34 weeks doesn't know how to suck, swallow, breathe. So they have to get tube fed, the tube in the mouth, down in the stomach, where they are fed pumped mom's milk or formula until they mature enough. And parents get very frustrated that they're not eating and going home. I try to say, well, it's kind of like a 6-month-old. You say, I really want this 6-month-old to walk. How many of you have kids? Okay, so you'll understand this. You say, I want my 6-month-old to walk. Let's practice every day. You get down on the ground and you walk with it. Come on, you can do it, you can do it. Is it going to help them walk? No, it will walk when the brain says it's time to walk. Same thing with eating. So we have to kind of convince them to just let the baby do what they want to do and learn how to eat. So sometimes it's just boring, if you will, feeder grower stuff, but a lot of parent communication, and that's where it's fun. Just talking to families, talking to moms and dads, and getting them to buy into the fact that the baby's not quite ready to go home, to be bonded with them, to come in and change the diapers and take their temperatures and those kind of things. So, like I said, for the most part, it's a very enjoyable job as a neonatologist. And you've shadowed, anybody else shadowed in the NICU? When Leslie was part of AMSA back in the day, she was looking for physicians to get shadowing, and she asked me, well, sure, we can take 3 every semester. So if you have an interest in NICU, I'm going to have to turn it over to somebody else. So since I'm retiring, I'll let Lita handle it maybe or somebody.
Yeah, there you go.
But anyway, so we can handle about 3 students per semester if shadowing in the NICU is something that is enjoyable. Or would be, possibly, because you don't know, with us. So, any questions about my medical school, my training, my fellowship? I can talk a little bit about these humanitarian trips I take. Yes?
Yeah, I was going to ask about that. I'm interested in global health, so I'd love to hear how you got involved in those trips.
I got involved in that trip when I was contacted by, I'm LDS, and I got contacted by the church to ask if I would be interested in going out. The church became involved in these programs about 2002. The program of neonatal resuscitation, which is a very regimented algorithm process where you take a baby who's not breathing at birth and what you do with this 30 seconds and this 30 seconds to get them breathing at birth. And I first became, I was actually pregnant with you when I took my first certification for NLP. I had to leave you a couple days later, so I hope they did it right, because they don't take them to class too.
There you are, something virtual.
So at the time they called me, I was actually a single mother of 3 teenagers and thought that I probably more needed at home than across the world, although that would have been a better place to have been. So I contacted them later on when I could do that, and they got all my credentials and everything ready, and started calling me to go on these trips. The trips can be as short as this one coming up is going to be 8 days. I've had several trips for 3 weeks long. And since I did the schedule for where I work, I could schedule myself off, and most of my partners are LDS and understand that, and will cover for me while I'm home, because I'll cover for them when they go to South American nations or whatever. But I'm sure there's other initiatives besides LDS Charities, which is what it's called, that goes out there. What we do when we go out there is there's a specialist couple who, one's medical and one's administrative. They are assigned an area of the world. You know, somebody's Spanish speaking, so they go to South America, Central America. Somebody's French speaking, so they would do French, Guyana, and other. Mozambique, there you go. Countries that have high mortality rates. Is it Mozambique, Portugal? Yes. Portuguese, yes, because when I went to Rwanda, the couple I was with, they also do Mozambique because they're Portuguese speaking. But anyway, so the country has to have a high infant mortality rate, meaning that too many babies are dying of birth, and that the church wants to rectify that and make that better.
Do you know what that rate is?
I think in the U.S. it's around 5 per thousand. We went to our meeting, it was about 27 per thousand. There's some areas I've been to like 50 per thousand. But you have to kind of worry about the Soviets when they give you their statistics, because you know they don't want to look like they're doing really badly, so they'll sometimes say, well, if you don't live for 2 weeks, then you don't even count as being born alive, so you can't be an infant death, and so you have to kind of take it with a grain of salt when they give you their statistics after you kind of look at the way the rest of healthcare is there. So then they contact the ministries of health and work with what we call a local champion, who is a physician, usually pediatrician, neonatologist for us, that then says, yes, I will work with you. I will be your champion here in the country to help find local trainers. We'll find you a facility to treat it, to sort of train in. We will, you know, here's hotels where you can stay in the safe areas and restaurants where you can walk to and those kind of things. And then once that's all done, they present it to LDS Charities, who okays it and funds it. And then they start calling volunteers from the list. I'm on the list of volunteers. We have nurses, we have nurse practitioners, we have respiratory therapists, and we have physicians and neonatologists that go out of office. Any one of those people can do the same level of teaching. It's not a hard class to teach. I've mostly gone to Eastern Europe and Russia. And they like it when I go as a neonatologist, because in those areas, nurses, to be a nurse, it's a high school degree. And so they want somebody, you know, I carry cloud, I guess, I don't know. The American neonatologist is here, so it brings people in there and gives it praise. So we then travel there, stay there, teach. There are long teaching days. We teach one class called Newborn Resuscitation Training, Newborn Resuscitation Program, which is a big 2-day course where we teach them to dry and steam a baby, give bag and mask. You know what bag and mask ventilation is? Chest compressions if the heart rate doesn't come up, intubation, adrenaline or epinephrine injections through an umbilical line. Most babies don't need all that. They just need to get breathing. So then they developed this class called Helping Babies Breathe, which is what we were teaching. That's all we taught when we were in Ghana. Rwanda.